Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
So today we have a special guest friend on our episode, Mark Faries. Mark, thank you for joining us for today's.
Great to be with you.
So we are.
That'll come out in post, definitely. We know.
Two special guests. Two special guests.
And two other special guests. Extra legs here.
Someone needs to feed the dog or whatever the dog's excited about.
Okay. So, Mark you are, right? Our first surgical oncology guest, right?
I think so. Yeah.
So, we obviously want to talk to you about a lot of surgical background in melanoma, as well as where you think we're going in the future, maybe past, current, and future states of lymph nodes and lymph node surgeries. But before we do that, we always enjoy talking to our guests and finding out a little bit just about them, about their background. Where did they grow up? Do their training? Where have they been, trained around this big US or world, as it were?
Well, I'm in lovely sunny Southern California now, and have lived here pretty much for the last 20 some years, but originally from the East Coast, and have some sort of a genetic abnormality in the family that leads them all to become doctors. So got grandfathers and my dad and my brother, and so not falling far from the tree. But my training was all on the East Coast until fellowship, and I came out here to be with Don Morton when he was at the John Wayne Cancer Institute, and that definitely has colored a lot of my viewpoints on lymph nodes and surgery and melanoma and immunotherapy and all the other things that Don was really a pioneer and a giant figure in. And sort of set me on my way.
That's great. James, I may end up having to kick to you a little bit more because the dogs are going a little crazy because the lawn people are here. But for a moment, they're a little quiet. Mark, Don, obviously you were with Don for a long time at institutes that ended up changing names and this and that. What were there any sort of like Mortonisms, as it were, any sort of things that you remember or still stay with you?
Yeah, so he definitely felt that in terms of surgery that there was no survival advantage to leaving tumor behind. That was one of his aphorisms, and that no tumor is resistant to formaldehyde. 100% response rates once you put it into the jar.
That's great. That's great. That's cool.
Yeah, I was just going to say, I always say that the response rate to surgery is 100%. I was at a kidney cancer meeting this morning, and obviously in kidney cancer, we actually do quite a lot of surgery for primaries and for metastatic disease as well. It's got quite a big role. And the one thing you can always say to the patient is at least you do a good operation and so on and so forth. A lot of the time it's coming out, and sometimes we're talking about ablative therapies and radiotherapy and stuff like that, and that's all fine. But actually, I think surgery is the gold standard in a lot of these types of situations, just to digress. Yeah. Anyway, Sapna, you were going to say?
No, I mean, I was just going to bring us to modern times. So now you're at... there's not an echo here. You're at the Angeles Clinic with an appointment at Cedars, right? How long have you been there?
Been formerly at Angeles for about 7 years now.
Okay.
But I had worked with Omid and the group here for many years before that. Just great collaborators and pioneers. So.
And as part of your training under Don Morton, you guys were really I was going to use the word Sentinel, cardinal in Sentinel lymph node evaluations, maybe starting even from the tracer, the dye being used, and then to remind us, medical oncologists, what was it called before it was called MSLT, like the Sun Belt trial? Or
it was a Sunbelt trial, yeah, Kelly McMaster's trial, and that wasn't a trial really designed to answer the question of whether lymph node surgery was beneficial really or not. There were kind of two components to it, a surgery component and then an interferon component. And they did PCR on lymph nodes and things like that. So an interesting trial, and we learned a number of things from it, but it wasn't really designed to figure out whether sentinel node, what clinical impact sentinel node or lymph node surgery in general had. But the whole MSLT and the sentinel node concept all flowed from this really ancient controversy in the field of what do you do with lymph nodes. And it goes back to a guy at James's institution, actually before it was the Marsden, I think, when it was the London Cancer Hospital, a guy named Herbert Snow there, who first proposed this idea of taking lymph nodes out electively or prophylactically. And so it started from there and set off a century-long debate. And, the neat thing about working with Don was, he was one of these truly larger-than-life figures. And there was a similar guy at the Marsden, Myron Thomas, who, had very, very strong opinions about melanoma and other things. But the two of them would get up at these meetings, and it was like, King Kong versus Godzilla sorts of interactions. And the debate was always, does it make any difference in the bigger scheme of things to take out lymph nodes that you don't know have disease in them? And it went through a whole series of elective lymph node trials, the Italians, the WHO, and the Swedes and the French, and then the U.S., the intergroup, Charles Balch, all did a series of randomized trials, but none of them settled the debate, basically, because none of them showed a significant benefit. They all showed significant benefits for subgroups. It was all sort of trending in favor of the lymph node group, but not by a statistically significant amount. But then when Don came along with the sentinel node concept, that made the whole idea of elective lymph node dissection moot, because you didn't need to do a full dissection anymore to find out what was going on with the lymph nodes. You could just do a biopsy. And so that fell by the wayside, and that led then to MSLT 1 and 2, and we'll get to 3 then.
Yeah. Can you, just as a bit of history, maybe take people through the design and outcomes of 1 and 2?
So 1 was to figure out whether it was similar to the elective lymph node dissection trials. So you have a patient who has a new diagnosis, doesn't have any evident disease in their nodes, and they get randomized to having their nodes worked on or not. And so there was an observation arm, and then the intervention arm was sentinel node. And if they had a positive sentinel node, they had a completion lymph node dissection. And then it was a comparison of outcomes of those two groups. And based on retrospective analyses of the John Wayne database and some other things that the intergroup had done, it was felt that only intermediate thickness would really be able to show a benefit. Thicks, it was always felt that the horse was out of the barn for them, and either they had spread beyond the nodes or they hadn't, and intervening in the nodes wouldn't make a whole lot of difference. And the thins had so few positive nodes that you would never show a statistically significant benefit because there were no events. So in MSLT1, the primary endpoint stratum was 1.2 to 3.5 millimeters, kind of random numbers, but that's what it looked like from the retrospective database analysis. It also enrolled thinner and thicker patients, but more as secondary endpoints, exploratory endpoints. So the trial required the whole world to complete, as many of these melanoma trials do. Leaned very heavily on Sydney So John Thompson enrolled about half the patients in the trial. We had to have him stop accruing because he was accruing too many. But the trial was done, and in the end, no overall survival, no melanoma specific survival benefit. It was about a 3.5% difference at 10 years, which was not statistically significant. Big difference in recurrence-free survival and local regional failure, that sort of thing was all very different, obviously. And a lot of prognostic information from the node. And when you looked at the group one of the problems with the trial was the event rate was too low. And so in the end, wasn't really powered to show a significant difference because most of the patients didn't have any disease in their nodes in either arm of the trial. So it diluted any potential effect. If you just looked at node positive patients, there's actually a big difference in survival. The early intervention group does nearly twice as well as the wait and see group. But you can't know who's positive before you do the study. Anyway, so based on the value you get from the node and staging information and the local disease control, Sentinel node was essentially established as standard even before the trial was done. And the trial really confirmed what everybody knew about it already. But then the obvious next question was, do you need to actually do the full dissection? So most patients, the vast majority of patients, all their nodal disease has been taken out in the sentinel node. And you go back and you take out the rest of the nodes, a more morbid operation, and there's nothing in there. It's all just benign lymph nodes. And so the question was, do you need to do that? And that's MSLT2. So patients who had a positive sentinel node get randomized to completion dissection or observation with nodal ultrasound as part of that observation. And then comparisons of survival, melanoma-specific survival over time. And the DCOG trial, the DCOG SLT trial was going on at a similar time frame, very similar design, a smaller trial, and they both showed the same thing. So you could decrease the regional nodal failure, and in MSLT2 that led to a decrease in recurrence or an improvement in recurrence-free survival overall, but zero indication of any difference in melanoma-specific survival, distant metastasis-free survival, any of those other endpoints. And so it took a little time for everyone's frame to shift after those trials came out, some longer than others, but the world has shifted away and essentially nobody gets a completion dissection anymore.
I have loads of questions.
Maybe I can just, I was just going to pick up actually. There were a couple of things anyway. So very interesting to talk about Marion Thomas, because I guess at the beginning of my career, Marion was still very active and he's now retired actually. But I see him from time to time. And it's interesting you should raise the sort of comparison with Donald Morton. But I think Marion told me once, I don't know if this is true or not, but both of them were the sons of coal miners. So Marion was from South Wales, and I think Don Morton was from Pennsylvania or something like that.
West Virginia.
West Virginia. I apologise. And I thought that was quite an interesting observation. You've got these two sort of opposed, actually, big surgical figures, but actually hailing from an extremely similar background, albeit on different sides of the Atlantic Ocean. So that's one thing. The other thing I was just going to ask you, on the subject of completion lymph node dissections today, 2024, 2025, what do you think the indications for that might be, if any, at the moment? Is there still a group of patients where you might be thinking about doing that or not really?
It's a pretty narrow sliver. So I always actually pretty much always discuss it, present it to a patient who has had a positive sentinel node and lay out actually a fairly similar set of considerations to what it was before the trial was finished. In that we get prognostic information from these nodes. You'll have a lower risk of recurrence based on not having a recurrence in the lymph nodes anymore. And here are the downsides here, the potential morbidities of the procedure. And prior to the trial, prior to the reporting of the trial, you couldn't predict what people were going to want to do. Everybody sort of had an opinion about what they wanted, but there was no great indicator of what somebody was going to decide. But essentially, as soon as you say there is no survival benefit to this over the long term, nobody wants an operation anymore. And so I basically presented, but assuming they're not going to want to have an operation. The patients who can't be reasonably followed, can't have their nodes reasonably followed, the CLL patients, people who are so remote, they're not going to be coming in for follow-up, people that aren't reliable. Those are the sorts of people where you still might consider it as a reasonable thing. And then there's some weighting about which basin. So I would be particularly reluctant to push somebody to have a groin dissection. But a neck dissection, that's not so bad. It's pretty simple, tolerated, not a lot of long-term downside to it. So there's some weighting that might go into it with that too.
Yeah, okay, that's great. Sapna, you were just about to ask something. I interrupted you.
I have loads of questions, but as I try to be reflexive in this process of doing the podcast, I'm trying not to be so dominating during these interviews. Mark, as you're describing the evolution from MSLT 1 to 2, I wonder was that where we started emerging with nomograms that could predict sentinel lymph node positivity or additional lymph node positivities, or did those already exist?
There was a lot of interest in trying to predict non-sentinel node involvement. I don't know. We may have become sophisticated enough statistically to come up with nomograms. Memorial has always been a big proponent of nomograms, but at least there were various papers that had some sort of a scheme for deciding who had a higher risk of non-sentinel node involvement and who did not. And they were pretty similar things. The volume of disease was probably the most in the sentinel node was probably the most powerful predictor. Age plays a role. The thickness of the primary plays a role. Those sorts of things. But it was never to the point where that was a big factor that was incorporated into the decision, the patient's decision. It was mostly somewhat. It was institutionally based. So some places, and I think Memorial is a very good example of this, sort of decided early on that they didn't feel, based on all of their experience, that there was a good rationale to do completion lymph node dissections. And they stopped really well before MSLT was done. And other places, even after MSLT2 came out, were still holding on to the value of sentinel of completion dissection and continuing to do it. And it took a while for that pendulum to swing away.
I wonder, obviously I know Charles Balch very well from my days at MD Anderson, and he liked, nomograms and risk calculators to some degree. I recently went to the MSK website to look at their nomogram. It doesn't look like they've really updated references or anything regarding that since the early 2000s. Maybe 2011 was kind of the last time. If for young surgical trainees, do you send them to go look at any risk calculators or nomograms as they're considering counseling a patient for potentially sentinel lymph node or even a completion?
Yeah. So mainly for whether to do a sentinel node or not. And I'd say the two most prominent kind of competing nomograms are the MIA nomogram and the Memorial nomogram.
Okay.
And they have different factors in them, actually. It's sort of interesting. But the Memorial one still has Clark level of invasion in it, which I can't always get our pathologists to even give me that. But they've been put head to head in a few papers that have come out. And Sydney generally outperforms the Memorial one a little bit. They're both decent. They're both better than just using AJCC staging as the way to decide. And then the other big kind of controversial thing at the moment is gene expression profiling as a factor for deciding whether to do sentinel node or not. And there's Castle as their Decision DX commercial test that's available, and they'll give you a percentage score. And now they've actually incorporated some of the other clinical variables into that percentage estimate for the nodal risk. But I have not found that one particularly helpful. We'll see patients that have the best class 1A sort of score who then have a 4.9. It often comes out at 4.9% risk of nodal involvement. And then what do you do with that exactly if 5% is the cutoff? So I think any of those nomograms is going to be better than just based on stage, and makes for a better informed discussion with the patient about whether sentinel node is something that they want to do or not.
It's a great transition. I still have like 3-4 topics I want us to hit on, but it's a great transition to what the NCC guidelines are now saying. So the NCCN guidelines are now softening sort of recommendations for sentinel lymph node. If you have a clinical stage 2, a discussion of sentinel lymph nodes certainly can happen, but it's not de facto that they need to go and you need to pathologically stage people as stage 2. Now, some of that, maybe I'll merge two of our topics. As the surgical world was evolving with MSLT and then MSLT2, the medical field was evolving, and we were transitioning from adjuvant interferon that was challenging for many reasons to adjuvant checkpoint inhibitor, which felt maybe a little safer and, still struggles with lack of OS benefit, but perhaps it's easier to offer that. But, just as we were evolving, first of all, the conversation was the benefit in stage 3, having given adjuvant PD-1, was in patients who had undergone a completion lymph node dissection. And that data was sort of coming to birth as your MSLT2 was coming to light, saying, hey, listen, let's not do completion dissections. So we have therapy that shows a benefit in patients that have had a completion. What is the benefit of that therapy if you don't do the completion? What's that gap area? We don't know, but it kind of made sense for us to figure it out in the real world. And now what has happened is we've got adjuvant therapy for stage 2 disease, but all the trials required that the sentinel lymph node was evaluated in those patients. So those were pathologic stage 2s. But now, of course, the guidelines are saying, well, maybe you don't have to. So for clinical stage 2, you've got some therapy. Again, we're in a gap. There is a percentage of clinical stage 2s that are pathologically stage 3s. So then what really is that benefit? As these two worlds are kind of emerging, we now have the guidelines that are probably struggling to keep up. They're going to split the difference and say you can discuss sentinel lymph node. What is your feeling of sentinel lymph node for clinical stage 2s? Is it a patient by patient decision, case by case, every patient in the office? Do you have some big feeling about how we should be approaching that? And obviously that has impact then for our adjuvant trials that might include stage 2. I've heard you say this before, but I don't have a handle on the numbers. What is the percentage of patients that we're calling clinical stage 2s that potentially are going to be pathological stage 3s if we actually go and do the sentinel lymph node? There's a lot of questions. Sorry about that.
Yeah. So, between the NCCN guidelines and the clinical trials no longer requiring surgical staging of the nodes for these clinical stage 2s, I think it's a mistake to not do sentinel node biopsy for those patients. There are certainly patients. So I saw a patient this week, 91, advanced Alzheimer's, thick primary. He's not going to get a sentinel node biopsy done, right? But by and large, patients should really have a sentinel node biopsy. I had a debate with Jason Luke on this in JCO a while ago, and so the argument from my perspective is you need that staging information. So I think you in the medical oncology community are still a bit on the fence about adjuvant therapy for stage 2.
Yeah, fair to say.
I don't think you're on the fence so much about adjuvant therapy for stage 3C, right? And that's the difference. So you don't go from 2B, 2C to 3A. That's not the transition that happens. If you have a positive node, you're 3C. And so I think knowing that information has a big impact on what what you would counsel a patient and what the patient would reasonably decide to do in terms of adjuvant therapy. So I think that's just that information is pretty essential. The other is the therapeutic effect of the sentinel node biopsy, which is generally discounted. So not a survival effect, although we could argue a bit about whether there potentially is a survival benefit, probably not for the stage 2s, but most of them are rendered free of any nodal disease by the sentinel node biopsy. So they don't recur in their nodal basin. Even the higher risk primaries, most of them don't recur in their nodal basin, and they never have to deal with a lymph node dissection or anything like that. That if you leave it behind, and in answer to the question, it's probably 35 or 40% of them have positive nodes. And we don't have a great handle on how big of an impact adjuvant PD-1 blockade has on nodal recurrence. The two trials are a little mixed so far in terms of how much difference there is in recurrences in the nodes, regional recurrences. So you're certainly not going to do better than eliminate half of those nodal recurrences with adjuvant therapy. So that's a bunch of people that are going to end up getting nodal dissections who didn't probably need to have them. So
it's a good thing for me to look at when we do the follow-up for 1404 is describe the percentage of nodal recurrences, not just recurrence.
Exactly.
Yeah, I mean, and the next thing probably maybe leading on from that is to talk a little bit about MSLT3. So I can pick up if you want. Okay. I mean, interesting to hear you say that. We in the UK, there's a lot of debating as well about the role of sentinel node for thick primaries, and some people have just stopped doing it altogether out of hand. And I have to say, my institution, we're still very much in general, both offering it and discussing it and doing it in these kinds of patients for some of the reasons that you've said. And I worry a little bit, honestly, that one of the arguments that sometimes gets touted here is the resource implications. So people will say something like, oh, we've got really long waiting lists, and so we're not going to do a sentinel node. And frankly, I think that's the tail wagging the dog, because you need to decide, first of all, what's right for the patient and then figure out the way to achieve it. So that's been a bit of a shame. Any case,
I once debated Dan Coit at the SSO about completion lymph node dissection or not, and I was pro completion lymph node dissection. He was anti completion lymph node dissection. Just sort of taking. I think we both agree with each other on all these points. But in any event, I had a slide of because I knew he was going to make the cost argument, so I had a slide with just a bar graph of the cost of ipilimumab, the cost of a year of PD-1, the cost of a lymph node biopsy, and you couldn't even see the bar for the lymph node biopsy. It didn't even register on the graph. So I think if it aids in using appropriate resources in the medical setting, then it's worth the cost.
Yeah, exactly. I mean, that's a great point. You're talking about orders of magnitude of difference there, as you say, in terms of cost. Okay, so what about MSLT3? Tell us about that.
So we're in a bit of a similar situation now with neoadjuvant. So with all the great work that has been done by Sapna and by the international collaboration, we know that patients who have neoadjuvant immune therapy, who have a very good response, do fantastic. Survival curve straight across the top of the graph, and exactly what you want to have happen. And the question now has become, can you pare back the intensity of any of their therapy? Can you de-escalate and still do just as well? And one of the prime areas where that might happen is in decreasing the extent of surgery for those patients. So in patients who have an excellent response in an index node, in the most suspicious node, if that disease is a complete response or a near complete response, do you need to do a full lymph node dissection? And so in the Opus and Neo trial, they looked at pathologic correlates between an index node and the full basin, and it generally correlates pretty well if they've responded very well in the index node. they've responded very well in the basin altogether. And then Prado looked at just using index node for these patients, and not, if they had a good response, not offering them a full therapeutic lymph node dissection. And those patients did quite well also, but not quite as well as they had hoped. And so there is still a question about whether or not there is a benefit to doing a full lymph node dissection versus managing the basin based on how well they respond in an index node. And so I think trying to uphold the tradition of the melanoma surgery group of answering questions with randomized trials, we would like to do a trial that asks that question. And Alex Vanakui has been pioneering this idea, has been pushing this idea in Sydney, and we're trying to get interest internationally because it'll require an international group to really do the trial. But we will take patients who are planned to have neoadjuvant immunotherapy, randomize them either to an index node-based management or just standard therapeutic lymph node dissection. They get their neoadjuvant. They get an index node, that node taken out and assessed. The other group just has a full lymph node dissection. And if the group that has the index node, if they have a major pathologic response, they don't have any more surgery done. If they have less than that, then they have a second operation for the full therapeutic lymph node dissection. And we'll compare recurrence-free survival between the major pathologic response groups. We'll also, though, look at morbidity. I mean, we know index node is less morbid than a full lymph node dissection. The question, though, will be, is having two operations, having an index node and then a dissection for the group that doesn't have a great response, is that worse than just having a therapeutic one operation, just one lymph node dissection? There's some hint that there may be some lymphedema risk that goes along with two separate operations. So those will be the sorts of things that will play out as the trial gets looked at. So we're hoping to get that going soon.
And maybe just a comment, Mark, about markers. So when we think of index node, a lot of times we like to mark that node. It's not going to be mandatory in MSLT3. Really, that becomes a cost issue of standardizing marker placement. But what are the choices for index node marking?
There are a variety of things. You can just place a clip that then can be seen by ultrasound, and you can find that node even if it regresses that way. That's probably the cheapest thing. But there are lots of other technologies that have come along, mainly used in breast for the most part, I think. The Savvy Scout that has a probe that can be used to detect it. There are other, there are magnetic seeds. There's another new technology that we're just getting that uses a different type of seed and a different type of probe. And they each have sort of pros and cons. And I think any technology will work just as well for this purpose. So we'll be, I think, agnostic to any of those things for the trial design. But the technology will probably change over the course of the trial as well.
Yeah, and then I guess maybe one final comment in the neoadjuvant space. Minimizing surgery is a goal. We've heard Lex Egermont and others sort of say more cures, less surgery, shorter time on treatment, as sort of the triumvirate of where we should be heading. And then, my friend Jen Wargo has often said she believes surgery to be immune suppressive. And we probably, I don't know if we have tangible handle on how immune suppressive a biopsy versus an index node resection versus a therapeutic or completion lymph node dissection. By the way, I know Alex Vanakui also is very particular about those terms. Therapeutic lymph node and completion lymph node dissections may not be interchangeable in his mind. Is there anything we know about immune suppression as it relates to surgery? What work can we do maybe as we're building out MSLT3? Should we be collecting maybe PBMCs and looking for immune suppressive markers? What do you feel as a surgeon?
Yeah, no, it definitely is immunosuppressive, cortisol surges and things like that. The magnitude of the suppression is almost certainly correlated with the magnitude of the procedure. A Whipple is going to be a lot more immunosuppressive than a lymph node biopsy. But then there's, I think, an interesting thing that the neoadjuvant trials have proven is that it's sort of this sequence and sort of the specific immunosuppression of the node itself. The sentinel node we know is immunosuppressed relative to the non-sentinel nodes. Alistair Cochrane was an early examiner of that, and there have been a lot of sort of interesting things that have been done looking at that. And the theory is that it's something coming from the primary tumor site that drains to that node, suppresses the immunity in that node, that then prepares it as a metastatic niche for the cells then to be able to the melanoma cells to grow. And so I think the interesting thing about the neoadjuvant is that you've now proven that you can, essentially specifically counteract that area of immunosuppression and reinvigorate those cells that are there. How long does that need to go on, to overcome and taking out that node prematurely then, takes away, it's suppressive specifically because it takes away those specific anti-melanoma lymphocytes that were in that node. And the same may be true even for stage 2 patients. Yorgos Karakoussis has a neoadjuvant study at Penn looking at stage 2 patients. So I'll be really interested to see what his immunologic correlates are in the node and those sorts of things that come out of that study. So I think there are definitely interesting things that can be learned about global immunosuppression that happens as a result of the surgery. And we don't have a great measure for that, though, I would say. So that will be sort of the challenge of what are you going to look at to prove that. But you would suspect it'll be much more for the full dissection group than it would be for just the mixed node group.
Well, all things old are new again. You're reminding me of incubation theory and, of course, these tumor draining lymph nodes, all the research in those tumor draining lymph nodes about, do you keep them in, do you take them out? If you take them out, are you taking out the immune suppression, but with it, are you taking out the anti-melanoma cells? So yeah, all great things. Maybe, James, I'll send it over to you to wrap up, if that's all right.
Yeah. Well, listen, first of all, thanks very much for being with us, Mark, our first surgical guest. I have to say, maybe I'm getting old, but I'm enjoying the surgical discussions more and more and more, because to be honest, sit in a room with medical oncologists, we all sort of say the same thing, we look at the same things, bit of an echo chamber, but actually it's fascinating to listen to you, Mark, truly fascinating. So thank you very much indeed for taking some time out of your busy schedule.
Great to be with you guys.
All right. Thanks, everybody. Have a good day. Let me stop the recording here.